Hi everyone, my name's Jared, and I'm here to discuss with you a complete misjustice and I believe illegal experimentation in Australian medicine. I'm using the outline of the Tuskegee report, which is the most famous illegal experimentation known so far, and I'm going to use the outline of that and proof that the laboratories are tampering with samples and our infectious diseases are deliberately refusing, and our medical staff, basically, the entire medical system really, is deliberately denying recognition of symptoms so that they can not treat diseases properly. So let me just go through what I'm going to run through here quickly. Is with the understanding is the subjects were not told about their diagnosis. Participants were being denied proper treatments or given fake treatments and placebos instead. In some cases, when subjects were diagnosed with having syphilis by the physicians, researchers intervened and prevented treatment. Well, in this case, it's not researchers, it's Australian infectious diseases. They've all written that, oh no, withhold antibiotics, he doesn't have an infection, blah, blah, blah. Many of the subjects died painful deaths of syphilis during the study, which was stopped in 1973 by the US Department of Health, Education and Welfare, only after its existence was publicised and became a political embarrassment. Well, that's what I'm here for today. Today I'm going to try and show you the proof that you need to basically help me and our community stop being tortured and abused by Australian medicine. In regards to a bacteria, I believe is Streptococcus discolactae, but it's a form of Streptococcus either way. What I'm going to show you first is the proof that of what I've done to confirm that the laboratories are deliberately refusing to identify this bacteria. We're going to discuss the human biomes. There are areas of native flora, your skin, oral flora, nasal flora, bowel flora. Then you've got your two sterile zones, which are urethral flora and blood, which are supposed to be nil, zero. Sterile zones. I'm going to prove that. I'm going to show that the infectious diseases that I've seen have lied about the availability of testing that confirms this disease, and even after all this information was sent through the public safety group and made its way to Brad Hazzard, our Minister for Health and Ethical Medical Research, I was basically told to keep letting doctors partially treat me or treat my symptoms as they thought, instead of treating the disease and making sure that it goes away and identifying the threat to our community as a whole. First thing to know about Streptococcus discolactae, it's an orally contagious bacterium, contagious person to person, animal to person and surface to person. So basically anyone who collects this in an area can cause an outbreak. There are many ways for this to be transferred, and it can come from animals, which is going to be represented in a case study by Virginia Boone in relation to liver, kidney and heart disease, which is linked to this bacteria. And there's also a lot of other information that's going to come through, but the first thing we're going to focus on right now, we're going to get underway. It's going to take a while. Unfortunately, medical stuff is complicated and it takes a lot to come around and recognise the symptoms, as well as I had to learn how to build my own culture plates, because Australia doesn't allow you to buy anything that's useful outside salt agars, which will really only grow fungus and that sort of things. It doesn't really grow bacteria. Any of your CSAs or your blood agars, they don't allow. I'm assuming so that you don't find out that they're screwing you over. So in another video I'll show you how to make these and how to build your own incubator at home so that you can test the laboratories yourself. And for now we'll show you what I've done, and we'll get onto the links of what they're deliberately trying to achieve here. And you're probably wondering, why would they do this? A simple fact is the amount of money in emergency medicine, from things like necrosis, sepsis, osteomyelitis. Emergency medicines they get a huge fund, plus they get the long-term stays and things in hospital, which is a massive financial boost. Then you've got the immunodisorders that they're claiming that are actually listed as symptoms of this disease, and we'll go through a list of those as well. And then you also got the research funding that they're going to claim for all of these immunodisorders that are actually symptoms of non-treated disease. So first thing we're going to do is we're going to go through how I prove that the laboratories are deliberately tampering with samples by using my urinary tract, which is the only sterile zone that I have access to. Obviously I can't go and get blood out of myself wherever I want. I'm going to prove that this growth that should be sterile in my urinary tract keeps coming back as a nil from the laboratories. Infectious diseases, Indi Sundararaja at Westmead Infectious Diseases said that he did 7-day cultures, because I believe at that stage that it might just be that they're not growing fast enough, but in actual fact it's that they're being deliberately denied recognition. So what I did here, the first thing I did was I took a sputum sample that was ordered by my doctor for this purulent, as they call it, sputum, and I added two colonies from this culture here. Now, by adding those two cultures, I had fully grown gram-positive cokies and fresh gram-positive cokies, and the result was multiple gram-positive cokies. So, therefore confirming that what I was actually growing was a gram-positive cokie. The next thing I did was I put that to the test to a microbiology study group on Facebook, and they identified Candidus albicans and Enterococcus just off a photograph. But later, after it was recognised as a gram-positive cokie, Streptococcus was also identified. Now, after that, I looked into, well, how can you tell the difference between Staphylococcus and Streptococcus? And it's pretty, I didn't realise quite how easy that was. There's only two gram-positive cokies, and that's Staph, which is a large separated colony, and Streptococcus, which is a large group of colonies, of smaller colonies grouped together. So therefore we've confirmed that it's a Streptococcus. The second test I did, to test the laboratories in this case, was I took this growth here, put this entire plate into a urinary sample, in the hopes of, if there's enough bacteria, they'll be forced to identify it. Now, the results I got back for that, zero growth in bacterium, just candidas. So they recognise the candidas but not the bacteria. Now, the third test I did for this was I took a direct urethral swab, which is growing this gram-positive cokie here, identified as a Streptococcus because it's small clustered colonies. And through private testing, which took me a long time to find because it's not well known, I requested it as a penile sample. Now, as a penal sample, it becomes a skin sample, therefore being available for native flora. All of a sudden, when you put it in a native flora area, there's moderate gram-positive cokies again. Now that proves that anything that comes from a sterile site, they claim nil growth, but if you put it in a native flora area, I've got a gram-positive koki. Now, this gram-positive koki identified as a streptococcus, and later on we'll go through the tests that confirm that it's streptococcus disgalactate, and how I got to that conclusion through research and through case study. But another thing that became apparent to me as I was doing this was my latest doctor gave me a request for that sputum sample that we discussed earlier. Now on this form, I've got written on it Streptococcus disgalactate, Enterococcus and Peptostreptococcus. Now, these three Streptococcus are related to a streptolysin O test, which I will get to in a little while as well, as part of the testing, and we'll go through that with the research. But I was told I can't do that again because tampering with a form is medical fraud, regardless of whether it's to try and save my own life. So, when I got private testing done, I got it listed as Streptococcus disgalactate. You'll notice with this, when they gave me this result, which is the same result that confirmed the gram-positive koki from a penal sample, that it's Streptococcus group B agalactate for nil growth, or not isolated. That means that they changed the name of the bacteria to prevent identification of the bacteria that was requested. And the reason for that bacteria being requested will be a part of the next section. I'm just going to go through, I'm just going to come and tidy this up, and I'll be back in a moment. But before I do, I want everyone to understand that this is a systemic bacterium. This is a systemic infection. So that bacteria from my urethral swab, if I had that I listed as a penal swab, it was moderate gram-positive kokies. If I had have put it in as a general sample, it should have come back as heavy gram-positive kokies, which again, anything that is plus or heavy has a chance of being a pathogen, therefore should be identified, which they're not. Doesn't matter where that sample came from or what it is. Heavy growth is not normal, and we'll move on to further things with that later. Now, in my next video, I'm going to actually show everyone how to make these, what you'll need to make your own incubator at home, so that you can test the laboratories yourself when you've got any of the diseases that I'm going to discuss with you in relation to this bacteria. And I'm also going to, we'll also have a bit of a discussion of some of the other bacteriums that are contagious just as easily, that I've noticed, that I've found in my local area, are not being identified until people are in critical health, or they're just being treated as an immuno disorder, being given a whole bunch of immunosuppressants, painkillers, steroids, anti-inflammatories, you name it. They're carrying a box full of stuff because they don't want to treat the underlying infection. And we'll get onto that subject a little bit later on too. So just give me a minute, I'll go back this up, and we'll come back and we'll move on to some of the research and the case studies that I've used to identify this Streptococcus as Streptococcus disgalactate, and we'll talk soon. Okay, we're back. It's taken me a couple of days to get back. Other people have had to use the system, and I had to sort of back away and come back. So, but here we are. Now, as we've been through the culture side of this disease and the confirmation that the laboratories are making sure that they don't identify it, we are going to now move on to the research and the case studies. I've reduced this down to one research article mostly and one case study mostly, and we're going to go through the way that the infectious diseases and the complete medical system in Australia is deliberately making sure they don't identify this disease. So I'll just point you down to the table so we can get the actual, I'll try and get you some of the actual literature up on the screen if I can. The first thing we're going to do is we're working with this particular article, which again I'll have scanned onto a link there for you so that you can go and actually read this stuff firsthand, because it's going to be, it's a bit hard getting the camera to pick up the words, but you'll find I've got highlights in these articles that point out the important factors and or around the important factors. So now the first thing we're going to do, first of all, we'll just flick through this real quick. So the first highlighted point is, after being considered non-pathogenic for many years, STSE is now recognised as an important bacterial pathogen. Well, there's two things there. I mean, the research itself is probably the most comprehensive research of an overall basis. It is mostly based on Group G Streptococcus disgalactiae equimillus, but also there's Group C Streptococcus disgalactiae equimillus, and these are both of these groups of Streptococcus have very similar outcomes. So I'm not really fussed on how the changes is, although it does mention Lancefield Group C and G from human origins. Now, when you flick over, you'll find that SDSD causes a variety of superficial, deep, toxin-mediated or immunologically mediated diseases in humans. The spectrum range from harmless superficial skin infections to life-threatening streptococcal toxic shock-like syndrome. Now, and you'll notice back in the first page there, it said that it was a recently recognised human pathogen. First thing that this does have a flaw on is that Streptococcus disgalactiae was recognised as a human pathogen it was recognised as a pathogen in 1885 and as a human pathogen in 1901. So when they come and say that it's a new upcoming, that's because they've only just started using the testing that's been around since 1935 to actually actively look at larger ranges than just, hey, you've got deep vein necrosis or you've got sepsis or bacteremia, which is when the bacteria gets to your blood, or your blood's shut off and you're starting to rot, or necrosis, which again is pretty obvious in itself. It's where it's eaten you away. And since that time, they've noticed its relationships to arthritis, osteomyelitis, pulmonary infections, which is infections of your heart valves, peritonitis, intra-abdominal and epidural abscesses, and this covers things like endometriosis and endometriitis, Crohn's disease, an irritable bowel, pretty much anything that goes with your vascular system, so your vasculitises, your peripheral sepsis, your urinary tract, your bowel, your stomach, and pretty much any of the tubes in your body. Meningitis, inflammation of the brain, endocarditis, which is a breaking down of the heart, peripheral septicemia, we've discussed that, neonatal infections, which again comes back to childbirths and also includes endometriosis and endometriitis, necrotizing fasciitis and myositis. Now, the description of myositis is actually going to come later in the case study that I'm going to use to demonstrate that infectious diseases are deliberately expanding this disease and ignoring symptoms, and it will be described. And streptococcal toxic shock-like syndrome. Now, The problem with those types of syndrome is we don't actually identify the toxins related to this disease besides streptolysin O in Australia. So therefore, a lot of this is just guesstimation work by the medical profession. I think things need to change, but as far as that goes, I'm not really sure how far we can go with that. Moreover, high rates of relapse and reoccurrence in group G streptococcus bacteremia has been noted. The literature suggests association between group G streptococcus bacteremia and other invasive infections and underlying conditions such as diabetes, meningitis, mellitus, alcoholism, and cardiovascular and neoplastic disease. Well, the first flaw I find in this research is that they're already mentioning that it causes heart disease, but then they're saying, oh, it's got an underlying condition of heart disease. So nothing's perfect in, but we'll do our best. Now on this next page, this is important here. This is if I can get it right on the screen, it'd be nice. This is the most common that you'll get list of tests of pathology that will come up on nearly every search for Streptococcus dysgalactiae, and the important outcomes of these tests is where is it? Streptolysin O, the M protein or monoclonal protein, the G protein, which is the G kappa lambda paraprotein, the bacterial capsule peptide or C peptide, and the necrotizing C5. Now we don't split that into A and B in Australia, but technically the C5A is the most common. It's the one that affects muscles and skin. And basically, it's a component that moves dead flesh from the body. It's the complement that deals with dead tissue, and it's most commonly only raised through infection, severe trauma, or burns. Are the three most common activators of this particular complement. I'm going to show here that the raises in the G kappa lambda ratio is a three-way street. There's one up or both up, which usually means infection. One down or both down is another, and one up, one down. Now, this ratio can tell you basically which way you should be leaning towards what the possible issues are. One up or both up is usually a sign of infection, and the other two I haven't checked up on for a while now, so I'm not going to designate which one was which again, because I can't actually recall. But one down or both down, and one up, one down. One is a sign of a cancerous cause, and the other is the sign of an actual immunodisorder. So in this, we're going to demonstrate that the traces of IgG kappa lambda, of the lambda ratio have risen. We're going to look at the at that ratio and the suggest of monoclonal gammopathy. The slight raises above normal ranges of the C the C peptide and the streptolysin O systems, which are the most important ones. And then we'll look into the raised necrotizing C5 and its ranges as well. Now, we'll start with the streptolysin O, because at the end of the day, when it comes to streptococcus, it's the first important marker, and it's important to understand that there are two ranges for this. There's a maximum normal range, and a maximum safe range for group A streptococcus. Now, this is becoming a bigger and bigger issue in the way of things, because the range for 3 streptococcus, not just Streptococcus dysgalactae, but Enterococcus and Peptostreptococcus, is the maximum normal range plus 10%. And that range is from 126 to 128 plus 10%. If you're above that range, then, and you're holding that for more than 3 months, then chances are you have an underlying condition with one of these 3 streptococcus. So we're going to discuss the 145 above 128. Now, I've had this range since first reference was in September 2017, and it has basically been raised ever since. I've had many arguments with doctors over, oh, it's not 200, it's not 200. Okay, 200 is the safe range for, maximum safe range for group A streptococcus. So you're looking at more things like, similar issues from group A streptococcus, or rheumatic fever, scarlet fever, and the risk of septicemia and bacteremia. You don't need the full range of 200 for these other bacteria. They don't create streptolysin in the same percentages. So, on top of being able to prove that, being able to show that, I mean, this is the last one in 2019 where it was at 128, and I still had a range of 145. So that's 2 years later, still had the same range. That's a bit longer than the 3 months required for this to drop down below, normally below 80, but at least below the normal range. But what in more recent times, recently it's been brought to my attention since my last private test done, is that even though my range had raised to 151, see that 200 right there, they've changed the receiving point from the maximum normal range to the maximum safe range for group A streptococcus. And by doing this, they're preventing people like me who actually look into their health and actually read the research past the first page of Google, that they are intentionally preventing the early diagnosis of these diseases. They're also only identifying the most severe of symptoms, if you've got necrosis or bacteremia or sepsis. Other than that, they're claiming, oh, it's psychosomatic, or it's this, or it's that, or it's that. It's not real. They can't see your symptoms. So we're going to go through a range of the symptoms that come with it. But next protein we're going to discuss is the M and G proteins. Now the M protein, which is your monoclonal protein, monoclonal activation process, is activated by the G-kappa lambda system. Now these two go hand in hand. And once you've collected these two, once these two proteins are raised, and they're not immunoglobulins, they're proteins, and doctors will try and mesh up with this all the time. These protein activations bring the susceptibility of the 3 streptococcus that it can be to 1. Enterococcus and Peptostreptococcus do not activate the M protein system. So once you've got activation of the M proteins, which we demonstrated in the testing over here, you bring your low range streptolysin and your G paraproteins and your monoclonal activation system brings it down to 1 bacteria, Streptococcus dysgalactae. Now that was my first indication that we're in the right direction. Now the second indication that I would like to bring to the table is the case. Particular case that, again, this is group G. I do believe that mine happens to be group C, but as I said before, They're both the same group of bacteria. They both cause the same lines of infections. And as you can see, it was a case of a man with sepsis, septic arthritis, myositis, and severe oral ulcerations. Now, you'll find highlighted in this section the first highlighted section. Oh my God, I'll get this right one day. Reads, on the physical examination revealed dry oral mucosa and a swollen tongue. On deeper inspection, multiple oral ulcerations were noted. Now, that was the first line of symptoms diagnosed in this case, and the second one, which explains here on the second page, on the next page, is about streptococcal myositis. Streptococcal myositis, which is characterized by muscle necrosis without abscess formation or primary inflammation of subcutaneous tissue and skin. Now, this means that it breaks down basically without any physical, visual, external factors. So you're getting basically what they call atrophy. I keep calling it subluxation because I work in dirt. So you got a sublux, you got a hole, you got to fill it in. So in medical terms, it's classified as atrophy. So they're claiming this atrophy is just atrophy. There's no bounds for it, so they can claim it's not a symptom. When mixed with the fact that you've already got the pathology, can prove that the laboratories are deliberately refusing the growth. Let's go into what they say they can't see. Now, the attention I've brought is this dry oral flora, which treated with antibiotics clears up nicely. And this oral ulcerations. Now, they say that, and I'll demonstrate this in writing from one of the infectious diseases. They claim they can't see this disease. They can't see those symptoms in the photos that were supplied. On this page, you'll see that this sinking in my hand is a form of atrophy compared to the other hand, which it doesn't show very clearly on here, but you'll see it better when you look it up on the screen. That is a form of myositis. Now they say it's just atrophy, and they did a very expensive scan that they claimed they couldn't see anything in regards to it. Well, I point out, see this large dark area here, and nothing in this other hand here. So you can see that this section is a large portion similar to the inside of my hand. You'll also note on this scan there are other marks down here going across my fingers and into the knuckles and up into the wrist on the other side of the hand, and again nothing on this hand. And we'll have a discussion on that. I've got some photos of that later. So they're the three main symptoms that were clearly obvious to see, and related back to a case study from this particular bacterium that I've proven that they won't identify even when it grows. They claim nil growth to prevent it, and they've lied about the availability of testing, and I'm going to show you that next. So let's get a start on that. First of all, I'm just going to go through each of the doctors and their attempts to deliberately force me to live with this disease. They've used every insult in the book. Oh, you're crazy, you're stupid, you're psychosomatic, that doesn't exist, there's no such bacteria, you name it, they've tried it. Oh, we can't use those tests because they're, that would be illegal experimentation. So it's illegal experimentation to use a test developed to identify infections, but not to refuse them for the purpose of not identifying an infection. Sounds a little bit cockeyed to me. So we're going to start with Dr. James Brownlee from Nepean Infectious Diseases. Now, this prick, and I will call it, this is going to get personal, because this is personal. These guys have stolen 6 years of my life. They've caused me agonising pain, and I've had about enough. And it's this constant half treatments and improper treatments that have made, and ignoring the reinfections. Basically, they've made this so resistant that they've created their own superbug. So, yeah, it does get a little bit personal. But anyway, now this guy is the first one that really upset me. For the simple fact, he sent me home saying I was psychosomatic, that my doctor shouldn't give me antibiotics because I don't have an infection. I have no signs of infection. He refused to test for group C and G disgalactae via any means, and sent me home with, and I forgot to highlight it, but he sent me home with, you'll see here, erythrocytes in my ejaculate, so basically bleeding testicles, claiming I had no sign of infection, and expected me to be nice about it. So when I got upset with him, he proceeded to give me an antibiotic as a peace giving, an antibiotic that I had already explained to him had been rendered useless against this bacteria, against this infection. He didn't care. The second one I saw was Dr. Jandeep Mandel, and he recognised the gram-positive cokies in sputum, right there, highlighted on the front page. And he also stated on the second page there that he would speak to infectious diseases about running the pathology mentioned previously of the M proteins, C5As and the C peptides, which he then came back and said, oh no, he can't run those tests. Those tests aren't available. Well, that's an outright lie, because I've proven that not only are they available, but when I actually got them done, I had to get that done again through private testing, which took me 4 years. 4 years to find a way to get done. Past the blockade of arm-crossed doctors saying, we can't help you, we won't help you, we will not identify this. Not only did I find out that they are available, but they are actually commonly used. The centre that I went to actually said they do 200 of those a month. So there's nothing rare, there's nothing strange, they just didn't want to do it. And they're not overly expensive either, so now the next one we're going to go to, then we went on to the Central West Specialist, Dr. Bryant, the ENT. Peter Bryan, the ENT, said, basically told me that with a history of sinus and headaches, from an ear, nose and throat point of view, I could see nothing wrong. Now, all he had was an x-ray and a scan, and he was actually requested to have a camera to put up my nose and check to see if there was anything that could be seen in ways of infection. This was requested by Dr. James Brownlee at Nepean Infectious Diseases, and also later on by, I think it was Dr. Mandel. So I did. So I went and I saw him, and he refused to put the camera up my nose, claiming there was no sign of infection and that he's not doing that, even though he's paid out of my pocket. It's not costing the taxpayer. It's costing out of my pocket $200 to get him to put the camera up my nose. He refused. And following that, my GP ended up giving me some antibiotics, in which case this necrotic tissue and then this septic tissue came out a couple of days later, before blood another couple of days later, before it cleared. Now, if you had to put that camera up my nose, instead of claiming that there was no signs of infection. He would have seen that there was necrosis up there, and he would have been able to help identify. Instead, he chose to do everything he could to prevent it. He also gave me insults about my mental state and told my practicing general practitioner that he should not give me antibiotics because I don't have an infection. So now we're going to go to specific case studies here, which now, is this what I'm supposed to wait for? This necrosis to eat its way out of my sinuses before an ENT does their job? No, I don't think so. Streptococcus dysgalactone. Left untreated, that necrotizing sinusitis would have eaten its way out. It's actually a form of necrotizing vasculitis, so it's an actual reduction rather than an inflammation. In controversy to necrotizing fasciitis, which is another one of the symptoms of Streptococcus dysgalactone, and that happens to be another case study, and that was transferred from a cat. And there's other ones there that we'll get into later, where with a long story, but basically there have been people with losing their entire fingers, losing chunks of flesh, having their entire sleeve of skin removed from the necrotizing mucinosis, which is another symptom here that we'll discuss in a little while when we get to it. Now, then we move on to Dr. Indy Sundaradara at Westmead Infectious Diseases, and Dr. Indy Sundaradara said that he ran 7-day cultures because at the time I believed the problem with it being identified was that it wasn't, that it has been known to be a complicated bacteria to grow. Since I started building my own cultures, which is after these guys, because I didn't believe a word that came out their mouths, I proved that bacteria does grow in a day or two, no dramas whatsoever. It's just they've either used a gram-positive resistant media such as McConkey, or they've just outright tampered with the samples or the paperwork. It's the only way they came up with nothing in their growth, with nil growth from my urinary tract, which therefore they claimed there was no streptococcus in oral or skin flora too, which I found amazing, seeing I've got those listed well and truly as gram-positive cochies on nearly 4 years worth of cultures. They're identified as gram-positive cochies plus, gram-positive cochie plus, gram-positive cochie plus, and I think I've got some copies of that in here somewhere too. I'm not sure, but if I have, we'll flick through the pages and I'll show you. He states that I remain disabled by my symptoms and report ongoing burning of his skin, throbbing of the veins and difficulty moving hands. Now, and that no new symptoms in the interim. Well, in that he stated that no new symptoms doesn't mean that the symptoms that are there aren't reoccurring and they're not constant. Now, he also put me through a $2,000 PET scan, which is the scan that I showed you that they say they can't see my symptoms in, as well as, and we'll get to Dr. Matthew O'Sullivan in a minute, Dr. Matthew O'Sullivan, who actually puts in writing that he could not see any of the symptoms that I've shown you in the photographs today, in the photographs. So, now Dr. Zandeep Mandel, and when I told him that I wasn't happy that, Dr. Indy Sundaradara, that I wasn't happy because he was ignoring what he was being told, and he also denied his ability to run the monoclonal activation systems and the G kappa lambda ratios, along with the C peptides and any of the others on that regular testing forms. So then we moved on. So he sent me to his higher up associate, Dr. Matthew O'Sullivan, who said, Jared showed me multiple photographs of various parts of his body taken on his smartphone which he felt demonstrated abnormalities. However, I could not see anything abnormal in the images. He is convinced his symptoms are related to a persistent disseminated infection with group C or G beta hemolytic streptococcus. So, well, I come back to the fact of I'm growing a streptococcus. I've confirmed that's a gram-positive coqui. I've confirmed it's a streptococcus, not a staphylococcus. Although in recent times I have had secondary staphylococcus as well, which is concerning, but that's another matter altogether. As to which strain of streptococcus, well, I don't know, because they're deliberately making sure they don't identify that. In here I've also got some of the pathology that they ran, including at one stage the G proteins, which noted that one of the paraproteins was raised, and they didn't bother following up on that either. We've already been through these guys. The only other one that I did show to infectious diseases, which followed up on the previous mentioned mucinosis, which has been diagnosed right here. Now, mucinosis is a breaking down of collagen, subcutaneous fat, or thinning skin syndrome. I also showed to both Dr. Indy Sundaradara and Dr. Matthew O'Sullivan that the changes between when things were bad and antibiotic treatment. They claimed they couldn't see any differences in the quality of the skin or the colours of the tips of the fingers or anything like that. It was just photo imaging. They can claim that all they like. I've got 100 people, including multiple nurses and frontline staff, who have said, wow, you look heaps different, even your skin. Another excuse they claim that I didn't have any signs of necrosis is that I didn't have any CRPs or ANAs, which are the main markers they're using for necrotic inflammation. You can't have necrosis without inflammation. Well, the first thing I already discussed is the difference between necrotizing fasciitis and necrotizing vasculitis. Necrotizing vasculitis is a reduction and a shrinking and closing of the blood vessels, basically, and causes the deadening of flesh around it and skin. And now this mucinosis rubbish can turn necrotic as well, and you can have entire sleeves removed, which is just horrible. But in the basic microbiology study group, they used the sheet of a Lansfield agglutination test to explain the CRP connections. And basically, as you can see, the group A is black because it is a CRP test positive, and then group B, C, D, F, G are blue because they are CRP test negative. And there's another point towards picking out the particular streptococcus that of concern, is that the CRPs say that it's not group A streptococcus. So while they're putting our streptolysin up to the range that only suggests group A streptococcus, they're refusing tests for any other streptococcus on the grounds that you don't have a high enough streptolysin. They're claiming that the CRPs say you haven't got necrosis, when in actual fact the CRPs related to don't exist in relation to any other streptococcus bar group A. Now, we also went through the PET scan, and I'll put a copy of that scan in there as well, basically saying that there's nothing wrong except a possible nodule in the chest. So basically they wanted to go down my throat and go into my chest with a surgical procedure. Again, another procedure that was unnecessary for no purpose except for feeding their own ego and creating an expense for the medical system. Now, you'll also notice earlier when we discussed the results from the scan about where my myositis was in my hand and the other side across the knuckles and the back of my hand. Now, I'm putting to everyone that if they hadn't have ignored that outcome, and this didn't say that there was no such thing, no symptoms available, which are clearly is clearly falsified, and the infectious diseases wouldn't even look at this scan, let alone try and connect it to any of my symptoms. Especially Matthew O'Sullivan, who told me that, oh, we don't question our colleagues. Well, and we'll get into the medical code of conduct in a little while, and we'll see if you're supposed to question his colleagues so that the patient can be informed of their condition. Now, as I showed you, the difference in the other side, not where the myositis is, but in the other side, I wonder if that could have prevented any of the damage on my hand, on the pinky and ring finger and up into the face of my hand. I wonder if that was a preemptive notification, or again, another thing they chose to ignore because, well, I have no rights as a patient. Now, in relation to how long I've been chasing this up, and even with the general practitioners I've been seeing, and this is one of my longest practitioners who more recently we had a bit of a discussion that ended that relationship, and I'll explain why. But I wrote this letter, and you can see it's dated is it the 18th of May 2018, specifically requesting strep C, strep G, and Pepto, and at that stage Clostridium difficile was still on my list. That was before I recognised that Clostridium difficile was actually a gram-positive bacilli, not a cokie. And the constant raised white cells and neutrophils that have been passed through all the medical systems, including infectious diseases, the ENT, and the physician, and through urologist, which I haven't got his report because I had a falling out with the doctor who that report was sent to, so I will get that soon. But basically shows I've got a history since 2016 on file here today, right through to 2020. Yep, till 2020, showing continuous raised high white cells, neutrophils. Now, all the GPs, infectious diseases, the physician, the ENT, and the urologist all say, oh, that's nothing, that doesn't mean infection. Well, white cells is the inflammation of the immune system, and by the time you get up to twice the range, your immune system is pretty messed up. And neutrophils are your body's protein relation to bacteria. So by deliberately refusing to identify those two blood counts, they're basically going out of their way to prevent, to not have to follow up on a possible bacterial cause. And I'll also bring your attention to the point of 7 times the normal amount of pus in my urine. And again, this has been through all of the and I can show the extension of time of that as well, with a second case of actual higher pus in the urine count. And this is where we get to the urinary tract infection that I've proven that the laboratories are refusing to identify, and infectious diseases, and basically anyone who sees it doesn't care. It's not their problem. And my argument is it is your problem. Now, and we get to the falling out. Sorry, the next doctor I saw was Dr. Nicholson, the urologist, who again put me through a medical procedure where he put down the white cells, neutrophils, and 7 times the amount of pus in the urine. Basically put it down like it didn't matter. It was irrelevant. These are the 3 magic points for a bacterial infection to start with. But then I after the urologist, he sent me into, he did a procedure where he went down through my urethra and checked out the bladder and all that sort of thing. And I asked him while he was doing that if he could take some samples to put out for extended culture, because nothing's coming up and they should be. He said, "Oh, no, we do that in urine. There's no reason for that." And I said, except for the fact that that whole urinary tract is supposed to be a sterile site. So anything that he took that anything grew, well, that's irrelevant. So basically after that, all I ended up with was no answers, 3 days of peeing blood, and then my stomach blew up like a balloon for about 3 weeks, until it started spreading to my bowel and I started crapping blood. At this point, I went back to my doctor, Dr. Sean Howlett at Wall Street Medical Practice, and I had at this stage my culture plates. I had my proof that it was growing from my urinary tract. I had my proof that it was growing from my mouth and skin, which basically he screamed at me, "I don't have an infection," and that I don't have any rights. I have to get everything from a doctor. And because I got upset and we had a bit of a scream match, because I told him outright that healthy people don't shit blood, and that if I was going to be a prick, I could use what I know about this bacteria against him in a heartbeat, which I don't deny. I can't. I can't condone my behaviour 100% of the time either, but I'm in pain and in fear of my life, and they're just screwing me around. But anyway, from there I got a letter saying basically, I can't help you from here on, and don't come back to my practice. So his idea that healthy people shit blood, and if they argue about it, they should go away and not come back. And then it came back to Dr. Karana Keat of Campbelltown Hospital, an immunologist. Now, an immunologist that again was brought up with white cells, neutrophils and urinary pus, claims there's no bacterial infection. Now, besides the fact that he's an immunologist, so knowing that white cells and neutrophils is the bacterial inflammation markers, and that 7 times the normal range of pus in your urine is not normal. If you've got that, you've got something wrong, and someone needs to find out what it is. It's just ridiculous. But in his letter back, he basically tells me that I need to stop smoking. Well, I'm a smoker. Deal with it. He told me in the start, if I didn't stop smoking, that he wouldn't help me, and that's another thing that we're going to have a discussion on when it comes to the code of conduct, as far as the medical practice in Australia actually giving a rat's ass what that is. He also noted that I responded to other antibacterials, and he basically told me that Matthew O'Sullivan and Dr. James Branley of Nepean Infectious Diseases and Westmead Infectious Diseases informed him to tell me that I have to stop because I'm pissing them off, and that even if I get this identified, it won't help me because my research is illegitimate. So the first thing I'm going to put out here is that my research, as far as the research goes, I don't claim any affiliations. I don't claim to have gained anything. None of that is responsible for me. That is direct. That is directly the ownership of the people who wrote it, the people who professionally instigated it. It has nothing to do with me. It's actually a part of, all I've done is point out the fact that it's a part of their medical training areas, and they should already know it. And he also put into the fact that it may well be that requires Bactrim prophylaxis Mondays, Wednesdays and Fridays to see if it resolves his symptoms. Okay, first of all, we'd already discussed the fact that Bactrim was no longer effective against this disease. So again, suggesting that someone takes an antibiotic that has already been rendered ineffective by previous lies and mismanagements. That just shows that you don't care. You didn't listen to a damn thing. And the second part of that is suggesting an antibiotic with a 12-hour half-life. And the only way I can really explain that is that it holds a level of bacterial resistance for 12 hours, where you can then continue that and still have protection to your next dose. So he suggests a 12-hour half-life antibiotic every 3 days. Well, that's well outside the ranges of its 12-hour half-life. Therefore, being a complete disregard for the antibiotic treatment itself. And this sort of behaviour is what's caused conditions like mine and superbugs in the industry. They keep blaming, they started off blaming people in the 80s for not taking their full course of antibiotics. Now they just refuse to give it to you. They refuse to give you treatment until your disease is gone. They're using things like symptoms-based medicine, which they say they can claim they saw or they didn't see a symptom anytime they want. And also we look at some of the symptoms. I mean, you look at symptoms like the urinary tract infections, the muscular pains, the joint issues, and they go, oh, we'll pick 3 of those. Now those 3 symptoms might be, say, lethargia, urinary tract infection, and and joint pain. Well, that's got a range of infections that's 200, 300 long. I don't know, it's huge. But to range a treatment on that is based on a guesstimation. They'll pick 3 of those and say, well, if you haven't got one of those 3, you haven't got an infection. That's just how it goes. But you've also got to look at the treatment value of that. Now, you take those same 3 symptoms and relate them to the actual disease that's causing it. So one might be from Streptococcus group A, and you might have just started with a sore throat and it might have just snuck away a little bit. 7 to 10 days of pretty much any antibacterial agent will prevent will kill that disease and prevent most comebacks. If it was from gonorrhea or something like that, a shot of ceftriaxone and a couple of azithromycin, you're laughing. Then you get into a complicated staphylococcus infection. Now, staphylococcus infection is usually about 2 to 6 weeks, depending on the severity of the disease. But how are you going to know that if you don't know what the disease is, because you're refusing to identify the bacteria? Another part, and then the next one says Streptococcus dysgalactae. Well, its treatment is 6 to 12 weeks. So how do you gauge from symptom-based medicine that you're treating a disease, not just symptoms, and creating a superbug by improperly treating the disease? I believe this is an intentional misguidance by medicine to expand their growth, and along with, as we discussed in the symptoms listed in the case study, in the research study, sorry, the range of what they're calling immune disorders that are actually underlying diseases of these types that they refuse to identify proves that they're just trying to make money out of it, and they don't care how much you suffer in regards to it. Now, the longest treatment for any of these symptoms that I'm aware of is leprosy. Now, it was a surprise to me to find out that we have 3 or 4 cases of leprosy a year in Australia. I didn't realise we'd ever have that. But the Bureau of Statistics is awesome. But the treatment for leprosy is 12 to 18 months. So if they're only treating your urinary tract infection for 10 days, how are they treating leprosy? They don't. They test for it. They have to test for it. And a lot of these things they do test for, but some of them they don't. Simple fact is, when you've got responses coming back saying gram-positive cokie, gram-positive cokie, gram-positive cokie, things like gonorrhea, Campylobacter, Helicobacter, and Klebsiella, and some of the others that, and leprosy, which is a bacillus, which I've been tested for 15, 16 times as a joke. Basic medicine should know the areas, the human biomes of what's native flora and what's not. And they should know that, at least the groupings of bacteria, that a gram-positive cokie can only be staph and strep. Gram-positive bacilli is Clostridiums and Listerias and Campylobacters and things like that. And then you've got your gram-negatives, which is your STDs and syphilis and E. coli's and Klebsiellas and things like that. So they should know these basic outlines, so that when they get a test back, they should be able to go, oh, yep, I see that. But that's only if they come back. And this is what we're here. We need to make sure that our labs are not tampering with our samples. We've got to make sure our infectious diseases and our specialists in immunology and urology, and they're doing the job. I mean, a urologist that doesn't know, that isn't looking out for what infections are affecting his area of speciality, sorry, you're out of line. Your responsibility is to know what's going on with people's urinary tract. Dr. Keat, it's your job to know what's going on with people's immune systems. It's your job. How about you get off your backside and do it? As far as infectious diseases goes, well, you're just deliberate. I've had enough of you. And that's why I'm doing this today. Now, I did put most of this file, including the fact that infectious diseases are deliberately refusing identification of symptoms, the proof that they're lying about the availability of testings, and I did get this as far as Mr. Brett Hazard. Now, now Mr. Hazard sent back to me after I got a phone call from Rebecca McLeod from the Patient Safety Partners in Bathurst Base, that I was actually on antibiotics at the time and my symptoms were being minimised. The disease wasn't treated to completion. So here we are back in reinfection and serious consequences again. Instead of offering me help to try and get the bacterial identified that, well, I suppose at that stage I didn't really have the proof that I had that, but instead of helping me with that, they sent me a letter saying, basically, continue letting doctors do what they're doing. Keep letting doctors screw you over. If a study comes up for Streptococcus dysgalactiae, we'll let you know. So, Mr. Hazard, our Minister for Health and Ethical Medical Research, says, after proving that his infectious diseases team are deliberately refusing, and so many GPs are deliberately refusing to identify the symptoms and the pathology of an invasive infection of necrotizing values, is I'll continue to let them doing what they're doing. Continue treating his symptoms. Don't try and find the disease, and this has to stop. I mean, you've all seen that Wayne Swan floating around your screens at the doctors with his big proud voice saying, hey, symptoms-based medicine, that's the best medicine. Well, that's a lie. And as we've discussed a moment ago, I can explain the reasons why that's a lie. And I'm also going to discuss that, because they're using symptoms-based medicine, they're refusing to identify the baseline diseases. So then they go, oh, it's a mental health issue. And I'm going to bring up the point here that of the mental health specialist that I saw at Blaney Hospital was a referral from a Dr. Niam Saman. Now, this guy told my wife and her friend that he would organise this testing for me. And then when I turned up on the day, he said, no, I can't run those tests, you're psychosomatic. So he sent me to his psychologist. His psychologist sent him back a report basically saying that, he can't explain my conditions from a mental health point of view, and that he can't see that I would stop until my concerns were met. To which Dr. Saman basically said, doesn't matter, I don't care, I'm not running those tests, I can't run those tests. No, that's a lie. He could have. He could have run them at any time, he just chose not to. So now we're going to work on the continued issues with this infection. Is, as we discussed before, this is an orally contagious bacterium, so it can easily transfer from person to person, animal to person, and surface to person. So I've had concerns about my family for a very long time, pretty much as long as I've been sick, and again with no follow-ups and no one willing to help me to make the connections. I ended up with my daughter having, from a previous injury, she ended up back in Westmead Hospital with necrosis and osteomyelitis. Again, not a single doctor took a swab of the wound, or did anything to try and identify the bacterial cause. They just went, oh, it's necrosis, and threw antibiotics at it, or it's infected, threw antibiotics at it, and then necrosis. And again, infectious diseases, Dr. Britton at Westmead Children's Hospital refuses to do anything in regards to identifying the streptococcus that was discovered when I took a swab of her wound. Now we can go through the fact that, again, we've proved this is a gram-positive cocci, small colonies and large clusters. It's the same streptococcus, or a streptococcus. My wife helped me put together an entire folder of information that links her symptoms, her lack of pathology, and the connections to this disease to Dr. Britton, to which he basically said, oh, well, it's an upcoming, it doesn't exist, blah, blah, blah. I'm not running those tests. I can't run those tests. So he said the only test he will run is a streptolysin O test, which, again, as you recall, 128 plus 10%. I don't know if you can read that, but hers was 181, I think it is, because you can hardly read it. And he says, oh, it's under 200, so it's under the maximum safe level for Streptococcus group A, but only just. And I can prove that even as a younger child back in 2017, she still had, as I do, the raised streptolysin O test. This has probably gone a little bit pear-shaped because it didn't go according to plans as I preferred, because as I said, medical stuff does go backwards and forwards, and it comes down to different doctors and the outright refusal to identify this bacteria. Including the file that I'm going to download, I've included some of the other case studies that link the lack of CRPs and the minimising of the immune response to this bacteria in regards to necrosis and other things. Necrosis, arthritis. And this is a good one. This is one I suggest everybody actually look up the full version of. This case study from Virginia Boone, linking liver, kidney and heart disease. Now we mentioned this earlier, and I like this very much because not only does it very thoroughly link the conditions of liver, kidney and heart disease to this bacterium, but she also included in that research the connection between communal dogs and the houses that they visit, and the transfer between them and the people that have become ill. My only dislike to that is that she does bring up the fact that many of her subjects died while she was doing the study. And it's the one thing I hate about these studies, is that they allow people to die while they are running them. Instead of going, hey, we think this is what it is, we found it in you, we'd like to treat it and see if it helps your fatal conditions. No, they don't. They wait and see what the outcomes are, and that just irks me to death. I think this crap needs to stop. Now, as we discussed earlier in the piece, I'm going to talk about some of the medical frauds and the tax fraud and the research fraud. Simple fact is, as you know, as noticed in basic research and case studies, you have things like myositis being claimed as an immunodisorder, fibromyalgia, lupus, endometriosis, sarcoidosis. What's my list here? Hang on. I've got a list of the names specifically brought up in research. Endocarditis, mucinosis, thinning skin, toxic arthritis, meningitis, peritonitis, osteomyelitis, which is necrosis of the bone. It also includes osteoporosis, pulmonary infections, heart infections, intra-abdominal and epidural abscesses, which is abscesses of the basically of the stomach lining, bowel, bladder, and so on and so forth. Urinary-sexual tracts and all that sort of thing. Neonatal infections, necrotizing fasciitis, myositis, and toxic shock. It's also listed as connected to several cancers. Basically, nearly every cancer of the mucosal system. So, mouth, throat, stomach, bowel, bladder, kidney, breast, and some others. I can't recall at this moment which ones they were, but it was also linked to directly mentioned is also endometriosis, myositis, bursitis, fibromyalgia, chronic fatigue, sarcoidosis, inflammatory bowel disease, psoriasis, polymyalgia rheumatica. I can't remember what that was. I think it was something to do with the joints breaking down. Rheumatoid arthritis, which is an inflammation of the joints, and Crohn's and ulcerative colitis. All these things are listed as symptoms if you follow the research far enough and into as many studies as you can, you'll find all of these things linked. Please don't stop at Google. Google's pretend. Go through, actually read the studies, look at the connecting studies to those studies. Follow the patients, follow the things that they already know. Now, these immunodisorders that they're claiming they don't know the answers to, and they're claiming billions of dollars in research value for, I can guarantee you there's not one of those research tests these people for Streptococcus dysgalactae, Helicobacter, Campylobacter, Clostridium difficile, and there are a few others there that are linked to a lot of these diseases as well as symptoms. They're not immune disorders per se, unless you've got failures in your vital organs, which obviously there's nothing you can do about those. My argument is, while they're deliberately refusing to identify bacteria, they're claiming fraudulent funds by not making sure that you haven't got an infection that's claiming immunodisorders. Now, remember earlier I said we'd discuss some of the cultures and the health, the medical code of conduct and how they're disobeying the code of conduct. So this is where I'll put all these on there. There's a bunch of them here, but you'll notice you'll be able to follow the gram-positive coaches and sometimes gram-positive bacillus up in + or in heavy growth. That was in a sputum sample, I think. Where was it? Oh, I won't worry about it just yet. But you'll be able to read and see where they all are. But you'll find the continuous connections are gram-positive coachi +++ or ++ at best. You'll also note that the time frame that they've been going over. So, with all of that in mind, with all of those things, we'll skip to before we go on to this, we'll go on to the tax fraud. Now, as you may have heard when I was talking about Dr. Keat and his reluctance to treat smokers. This is an orally contagious bacterium, so smokers put their hands to their mouths an extra 300 to 600 times a day. So the chances of them catching one of these bacteria that can enter the body and cause serious disease via surviving oral flora, which means you've only got to touch your mouth, touch your lip, and lick your lip, and all of a sudden you've got a problem with this bacteria. So these bacteria would be of a raised factor for smokers. So when you've got, it causes things like vasculitis. So let's go into oral vasculitis. They're claiming mouth cancers. Now, if you look at the cancer, the guy who's lost his tongue there, and look at the back, you'll notice the dry, hairy flora of his tongue. That is a sign of an underlying infection, of inflammation of his tongue. This is something that should not have. This is something that should have been investigated well before it turned cancerous. Necrotizing vasculitis and peripheral septicemia, right there. And as we discussed, some of the cancers, lung cancer is another one of the ones. I mean, this guy died 47 days later. Well, I've known people who've had lung cancer for many years, and it's taken them a long time to die. And I can't argue that maybe some people do die that quickly, but the fact that he's atrophied so quickly in that period of time indicates that there was something else going on. My suggestion is he had one of these necrotizing infections, and doctors don't give a rat's because they can make money out of it. Don't get me wrong, now, and there's kidney and bladder cancer as well. These things are listed in the research as symptoms of untreated disease. So why is it that they're claiming it all comes back to smoking when as easy as putting your hand to your mouth and licking your lip can cause these diseases? Now, don't get me wrong, I am a smoker, but I'm not an advocate for smoking. I think smoking's stupid. Anyone who starts needs their head kicked in. That's just dumb. Will it improve your health to quit smoking? The answer is yes. Can I deny all the symptoms on the front of that packet? No. You're not going to have good teeth if you're a smoker. You're going to have crap teeth. And you'll end up with things like dry sockets. You're going to end up with half your teeth. It happens. And it's obvious, it's right there. Emphysema. I can't find anything other than smoking that causes emphysema. It doesn't relate back to any of the research. And there are a few other things that they put on there that there's not much you can do about. I can't find any other alternatives. I'm not here to advertise that you should smoke. I'm not here to do anything for that. I'm actually against smoking. If my kids start smoking, I'm going to kick their ass. But what I am going to do is point out the fact that symptoms of this disease are being used without testing of this disease for an excuse to claim financial gain by the government for medical costings and blah blah blah. My argument is that the medical system is causing these things because they claim so many doctors now are saying, oh well, we won't treat you because you're a smoker. Well, that's no excuse, and I'll explain why. Part of the health regulations here, and I'll point out things as we go when we get to them. Health practitioner must maintain the necessary competence in his or her field of practice. So my argument here on this first point is, I've been sold by so many doctors now, especially the GP system, that no, they're not microbiologists, so they can't say what bacteria is part of the male urinary tract or what a gram-positive cocci is. I'm sorry, basic medicine tells you that should tell you the native biomes of the human body at best. Should you have scans or mediums, mouth and bowel, they're going to have up to medium growths because they're your body's biggest protection systems. Your skin's going to have light to moderate growth because it's again part of the protection system, as well as being the firmest protection against everything else. They should know these basic things, the basic outlines of diseases. Gram-positive coccis can only be Streptococcus and Staphylococcus species. Gram-positive bacilli can only be Clostridiums or alike. You know, they should know the basic outline so that they're not running 1,000 tests like, you know, me being tested 16 times for gonorrhea because I've got urinary pus. It can't be gonorrhea. Everything's gram-positive cokey. How can it be gonorrhea? It's just a waste of money, an intentional waste of money. Health practitioners must not use his or her professional or particular qualifications to mislead, deceive his or her clients as to his or her competence in his or her field of practice or ability to provide treatment. So all of these doctors that have said that they can't run these basic, everyday, common tests, are they being misleading about their field of practice and their ability to provide treatment? My argument is they are. A health practitioner must not attempt to dissuade clients from seeking or continuing with treatment by registered medical practitioners. Now, I've had nearly every infectious diseases, an immunologist, a ENT, and a urologist all tell my GPs they shouldn't treat me, I don't have an infection. So all these recurring symptoms that they can't see don't exist, and I don't have an infection, therefore my GP should stop trying. My GPs send me to these people to try and get help, and although in the end they've let me down mostly, in a lot of regards I can understand where a lot of them have been dissuaded, and after the threat from Dr. James Branley and Dr. O'Sullivan, I'm not surprised. These guys think they've got the right to bullnose and make people feel threatened by their actions. A health practitioner must accept the right of his or her clients to make informed choices in relation to their health care. So by denying symptoms that you can clearly see with your own eyes, let alone with what's in the scans, by claiming that you can't run basic pathology that is everyday testing, and refusing point blank, arm in arm for years, to refuse testing and deliberately tamper with cultures, how am I getting to make any informed choices about anything? Any demand for antibiotics is met with abuse, insults and arrogance. There is no way that you can stand up against them. You have no rights. And now, keeping in mind that this complaint, I mean, going through the HCCC, one, I'm dyslexic, so everything has to be in writing, which is a complication for me. Two, this isn't about individual doctors. This is an entire health system, including our governmental background, and I've had enough, and we need to stop it. A health practitioner must not provide services and treatments to clients unless they are designed to maintain or improve the client's health or well-being. Well, most of these are designed to improve people's health. Giving antibiotics that improve people's health, that visibly improve people's health, until those symptoms do not return, that is the best way. And I'm sorry, they're denying me things that I should be well and truly engaged to do. A health practitioner must not engage in any form of misinformation or misrepresentation in relation to products or services he or she provides, or as to his or her qualifications, training, or professional affiliations. That's just a joke. I don't think I even need to respond to that. Okay, that's the end of the public health regulation. That the main points in that. Now we're going to the Good Medical Code of Conduct for Australian practices, and let me start. We'll only stick with the highlight because we haven't got all day to be here. They must be ethical and trustworthy. Hang on, I'll start from the top here. Doctors have a duty to make the care of patients their first concern, and to practice medicine safely and effectively. They must be ethical and trustworthy. If they could lie straight in bed, it'd be trustworthy. If they weren't insulting, they could be trustworthy. If they weren't doing everything in their power to prevent you finding out about diseases so that you can be treated correctly, they'd be trustworthy. Patients trust their doctors because they believe that in addition to being competent, their doctor will not take advantage of them and will display qualities such as integrity, truthfulness, dependability, and compassion. Yeah, we'll leave that one alone too, shall we? Doctors have a responsibility to protect and promote the health of individuals and the community. Now, I'm pointing out that this is a highly contagious community outbreak-linked bacterium. There are cases in, I think it was Canada, it's 5,000 in one town. In India, 300 or 400 in 2 or 3 towns, several times over. This is an outbreak-linked bacterium. So when it's not here, not a big concern, but when it is here, when it does come, it can take over entire communities and cause serious issues. So tell me, where are they looking at for not only their individual patients but the community at all? I mean, any doctor, every doctor, including Dr. Britton, Dr. O'Sullivan, Dr. Branley, Dr. Keat, all of them are all looking at, hey, the patient in front of you, I can't see anything, I'm not doing anything, there's nothing for the community. You need to focus on you. How are you focusing on one person and protecting the community from diseases like this? You can't do it. Good medical practice is patient-centered. If they listen to what a word a patient said, they'd actually be able to cure people and help them. It involves doctors understanding that each patient is unique and working in partnership with their patients, adapting what they do to address the needs and reasonable expectations of each patient. Well, all I'm getting is direct. I'm going to fight you on every step of the way because we refuse to identify this bacteria. So I don't see how that has anything to do with respecting their patient and accepting them as individuals. The fact that I can put a culture plate in front of them that proves something's there that their claim isn't, and they can say, well, that's illegitimate research, so you can't use that. That just proves intent. There are many ways to practice medicine in Australia. The core task of medicine are caring for people who are unwell and seeking to keep people well. Well, I've had several doctors get me to the point where I was well. At one stage there, I was well for about 6 weeks. Everybody noted how well I was except for the doctor. The doctor, when I went back and told him that I'd been reinfected by this disease, and keeping in mind that in the research you'll find it has a 89% reinfection rate. And it was also mentioned in the case study, in the research study that was provided. They just ignored the fact until I was necrotic again. And now, where is that making a patient well and continuing to and seeking to keep them well? They're not doing anything about protecting the community. They're not doing anything about identifying the bacteria. They're not doing anything about treating the entire family, including the animals, because of the crossover of infection rates. They're not doing anything to protect neither me or my community, so I don't see how they're keeping within the practices of good medicine. Providing good care. Formulating and implementing a suitable management plan, including arranging investigations and providing information, treatments and advice. And again, you'll find all of this, you can read this whole lot, but the ones I'm focusing on are highlighted. I'm sorry, but they're advising you of things, they're refusing to identify things, and then they're trying to advise you that you're mentally unfit, or that you're, there's something wrong that's not to do with them. It's all about you. I find that completely impossible to believe. Recognising and respecting patients' right to make their own decisions. We have no rights. You go to a doctor and you say, mate, I think I need this antibiotic for this infection. They'll do nothing to help you. They will do nothing to help you identify that bacteria. They will definitely deny you that antibiotic because it wasn't affiliated by them. Therefore, they won't supply it. You have no rights when it comes to medicine in Australia. That's a lie. Considering the balance and benefit of harm in all clinical management and decisions, well, I'm sorry, forcing people to live with a disease by deliberately refusing to identify it. How is that? And refusing them antibiotics, which can cause other complications. I get that. But not as severe as the complications of not treating the disease. That's what they're designed for. Treat the disease, identify the disease, treat it properly, treat it once, and it goes away. There's none of this other crap, and you don't need to worry about the benefit of harm. Providing treatment options based on the best available information. Well, again, I can't blame so much my GPs on this basis. The GPs are doing the best they can with the information they've got, except for the fact they look at me and they go, shit man, you're sick. However, doctors like Karana Keat, who are specialists in immunology, who know that the pathology that follows is an infection. And infectious diseases that are microbiologists, their job is to take the take the samples themselves, grow the samples themselves, investigate those samples themselves. Go and check on those, see if anything is growing that's not being identified by the lab, and identify upcoming threats to the community. And this is where infectious diseases gets me, because, and they really piss me off, because there are three roles of infectious diseases in Australia: identify upcoming threats to the community, treat complicated infections, and orchestrate complicated treatment plans. The first one, identify upcoming threats to the community. How are they doing that while they're still denying that bacteria cause infections? They're deliberately, as you can see from my culture plates, either not checking on those plates, which are being interfered with by the labs, or they're doing the same ignorance. They're microbiologists, it's their job to go and check those and make sure that they're right. Taking steps to alleviate patient symptoms and distress, whether or not a cure is possible. So when you go to your doctor and you go, hey doc, I feel sick, I'm going to show you these things, my hand's splitting open, my mouth's covered in crap, I can't chew on anything, I can barely walk on my hips because of the pain, I can barely stand up because I'm so exhausted, and you go, I'm pretty sure it's bacterial orientated, here's the pathology that says it is, here's the pathology that says I think it's this bacteria, here's the bacteria in front of you, and they go, oh, you know what, I'm not giving you anything to alleviate that, even though we've proven that antibiotics reduce those symptoms. We're not going to give you any of those antibiotics, even though you're worried about your heart palpitations, and even though you've walked into Bathurst Base Hospital in convulsions, you're still psychosomatic, and we're not going to do anything to help you. I'm sorry, not good enough. They're not doing anything to alleviate symptoms or stress. They're creating it. They're creating it by deliberately forcing people into dangerous situations. And if anyone strikes back, like that poor fella who struck back and got arrested on the day, and had a heart attack, being arrested, I'm sorry, being arrested is stressful, but not enough to give you a heart attack unless you're an unhealthy person. They deliberately left him unhealthy. That was intentional. And because he reacted, he suffered the consequences. This shit needs to stop. Encouraging patients to take interest in and responsibility for the management of their health and supporting them in this. Again, you've seen the video. Do I need to go there? Let's just leave that alone. Decisions about access to medical care. Treating your patient with respect at all times. Peg's bum. All they have is their own ego, and there is nothing else that matters to them. They have no respect for you at all. None of them. Well, I lie. There have been a rare few. Dr. Joe Quirong, I'll give you a heads up, mate. You were brilliant. Even when you were told, stop, you went, I can't do that. You're not well. You're great. It wasn't your fault that these pricks wouldn't do their job. And for a while there, Dr. Sean, mate, You did, but then when it come to the crunch, you dumped me. You put it on me, and you left me in dire straits. Stick it. Not prejudice your patient's care because you believe a patient's behaviour has contributed to their condition. Again, I'm going to point back to Dr. Keat, who's telling patients, who's informing people that he won't look at you if you're a smoker. Sorry, that cannot prejudice patients on their behaviour contributing to their condition. You cannot do that, Mr. Keat. It's against the code of conduct. Kiss my backside. Giving priority to investigating and treating patients on a basis of clinical need and effectiveness of proposed investigations or treatment. I'm sorry, it's been proven over and over again that my symptoms reduce with antibiotics. My symptoms go away. This doesn't treat immunodisorders, it doesn't treat viruses, it doesn't treat fungal causes. It only treats bacterial causes. So if antibiotics are taking away symptoms to the point where my tongue can go completely clear and pink from furry and brown, that's a sign that it's been caused by a bacterial agent. Stop arguing, just do the job. Being aware of your patient's right not to provide or directly participate in treatments to which you can, being aware of your right not to provide or directly participate in treatments to which you conscientiously object, informing your patients and, if relevant, colleagues of your objection, and not using your objection to impede access to treatments that are legal. So I don't care what your objection is. I have a right to treatment, any treatment that's legal, and quite frankly at this point I believe the only treatment I have left is the treatment that is used in the case study provided in this folder. And again, I'll let everybody read that, the treatment there's, and the understanding of the particular antibiotics is registered, is listed in that case study as well. Working with patients, section 3, being courteous, respectful, compassionate, and I highlighted this one, honest. They couldn't be honest if they fell out of a tree, or fell out of the lie tree. Encouraging and supporting patients to be well informed about their health. Pig's bum, they're going out of their way to make sure that you don't get this information, make sure you don't get bacteria identified, to make sure that you don't get what you need to prove that they're doing the wrong thing, and profiting at your expense. This needs to stop. If you do investigate your own thing, you've got a mental disorder, you're stupid, or you're crazy, or you're psychosomatic, and this goes on your record and no one looks at you right. And I'm sorry, psychosomatic people don't have a heart attack from stress of being arrested. That's a medical issue. You're a bunch of bastards. Listening to patients, asking for and respecting their views about their health, and responding to their concerns and preferences. No, you don't. Not a chance. Not even close. You don't care. All you care about is your own ego, your own power of position. This needs to stop. Responding to patients' questions and keeping them informed about their clinical progress. Well, yeah, I think we've passed the point where we know that that's even worth discussing again. Let me see, down to good. Working with the healthcare system. Upholding the patient's right to gain access to the necessary level of healthcare and, whenever possible, by helping them to do so. Not a chance, you're not doing that. Supporting the transparent and equitable allocation of healthcare resources. Transparent? You got a brick wall standing in the way of patients getting the right treatments and the right identifications of disease. You all need to stop. Doctors have the responsibility to promote the health of the community through disease prevention and control, education and screening. You're deliberately making sure you don't identify things. Why? How is that promoting the health of our community? You're not. You're murdering people on purpose. I've had enough. And understanding the principles of public health, including health education, health promotion, disease prevention and control and screening. Well, you ain't doing none of that. And that comes back to the patient health. What were they? The patient health unit. And even our minister, Mr. Hazard, who says keep letting doctors deliberately refuse identifications, keep letting our labs continually mess with samples so that you don't get identification, you don't get proper treatment. So let's just say that the HCCC, I mean, they've got a role to play in an individual doctor here and there. They can't take on the entire medical system and the New South Wales and the Australian government on their fraud, illegal experimentation and deliberate torture of people in their community. Has to stop. Now we're going to go through a quick run through the declaration that these doctors took when they took on their roles as medical professionals. I solemnly pledge to consecrate my life to the service of humanity. No, they don't. They consecrate their life to the survival of their supremacy and their deliberate and their ego and their right to do whatever they want with disrespect for patients. And I've proven that with everything that I've done previously to this. I will give my teachers the respect and gratitude that they're due. Well, that's if they're due. If a doctor that's teaching doctors to be narcissistic ignorance and they become aware of that, they deserve no respect. You can't respect someone who doesn't earn it. Respect is earned, not given freely. So just because you're new doesn't mean you have to respect someone who's forcing you to injure people or do anything disrespectful. I will practice my profession with conscience and dignity. Well, yeah, you're keeping dignity to yourself. Shame about your patients. The health of my patients will be my first consideration. What a load of crap. I will respect the secrets that are confined in me, even after the patient has died. Well, you know what? That's one point where I do agree. They even protect your patients from the confidentiality of your patients. That side we can't complain about. I will maintain, by all the means in my power, the honour and noble traditions of the medical profession. Well, I'm sorry, if medicine's noble tradition is to force people into disease and basically see what happens, that's called a tradition of illegal experimentation. It needs to stop. I will not permit considerations of age, disease, disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing, or any other factor to intervene between duty of my patient. Well, I can't comment on that one. I'm generally a white guy. I cop the same from everybody, so I don't know how any of you other guys are being treated from different nationalities. I do know that the Virginia Boone research it was done in an Aboriginal community, and they do use the reverse, saying, "Oh, you're not Aboriginal, so therefore you've got a different biome." Blah blah blah. What a load of crap! It even states in the research that there was no difference between the white population she tested and the Aboriginal concentrations. I will maintain the utmost respect for human life. Seriously, we don't need to go there. I think that's self-explanatory. I will not use my medical knowledge to violate human rights and civil liberties, even under threat. Well, in actual fact, it's the opposite. You're deliberately going out of your way to refuse to help patients, even under threat. You know, when they're to the point where they feel they have to threaten you and your system, you're still being a lying prick and refusing treatment. Good luck. Thanks for that. Appreciate it. They say, I make these promises solemnly, freely, and upon my honour. Well, I'm sorry. There's all the way from government level, I find there is a lack of honour. It's a complete disgrace. Now, I do have a lot of other things that I could go into here. How I've recently started with a secondary staph infection, which is one of the two main complications and raises in mortality rates of this disease, and how I came across that and how I had that discovered. It wasn't through medicine again, it was through private testing. Cost me a fortune, but was well worth it. And that staphylococcus infection has taken priority. I still haven't gotten back to my doctor yet as to find out whether they're identifying that staphylococcus as well, or whether they're going to put that in the nil growth column as well. So we'll soon find out. I'll let you know. I'll let you know when I'm doing my videos on how to build your own culture plates. But for now, sorry it took so long, guys. Sorry it gets a bit out there at times, but this is me doing my bit to fight for the health and safety of my country. Thanks for listening. Thanks for watching. And you know, I don't need a subscription. I don't need a like. If you really want to help make sure this doesn't disappear, get it put onto, save it down somewhere. You know, put it where you can. You know, make something come of it. I'm not in it for the money. I'm not in it for the fame. I'm not in it for anything other than the fact that this crap has to stop. So yeah, please help me stop this medical fraud and protect lives. It's important. Thanks.